Welcome. Thank you for joining me to learn about the Bayley Scales of Infant and Toddler Development, 4th edition. Hi, I'm Dr. Melissa Ross, clinical psychologist. I've been using the Bayley Scales for over 15 years. I specialise in premature and at-risk follow-up for children. I am excited to introduce you to an engaging and well-standardised tool to assess child development.
The Bayley-4 module includes actual Bayley-4 items and materials. The materials in the training module are protected by federal and international copyright laws. The qualified Bayley-4 user is hereby granted non-exclusive revocable permission to access the materials for his or her sole use. The materials are not for use by any non-authorised user or for any other distribution. To complete this learning module, you should have access to the following resources: course outline, copy of the slides, and access to the administration and technical manual for reference. Please pause the presentation to check that you have the noted materials. In order to apply this tool to the clinical group you are working with, it must be administered in a standardised manner. This module will cover the background for the Bayley-4, structure and content, standardisation, and psychometric aspects and clinical group comparisons. The Bayley Scales is used to assess the current developmental functioning of infants and young children aged 16 days to 42 months via observation. The child is presented with a range of interactive activities that are novel, interesting, and engaging. Structured caregiver questions assist in scoring and decrease anxiety in the caregiver and the child and increases the validity of the assessment. Administration of each item is standardised but flexible. The administrator may vary the sequence of the items. Although the items are sequenced by degree of difficulty, they are not always administered in exact order of difficulty. The administrator may skip an item and go back depending on how the child is responding and the child's level of interest in the item. Each item is administered and scored in a standardised manner. So where did this tool start? In 1969, Nancy Bayley, a psychologist, looked at the unfolding patterns of development. She developed the original Bayley scales with an age range of 0 to 30 months. It included 3 scales: mental, motor, and behaviour. In 1993, the scale was revised. The age range was extended from 30 to 42 months. It incorporated theoretically based concepts including object permanence, recognition of novelty, memory, etc. In 2006, the scale undertook another revision. It looked at the building blocks of future ability, numeracy, play, etc. It included 5 distinct scales. Cognition became distinct from the child's language development. The movement component was retained. It provided an easy, user-friendly structure that was flexible and engaging for infants and young children. It drew on research that identified typical normal development in young children. The Bayley-4 is a revision of the Bayley-3. Some items are the same as those on the Bayley-3, and some have minor modifications. You'll also find some brand new items on the Bayley-4. The Bayley-4 provides culturally specific standardisation, census match to Australia and New Zealand. It has a polytonomous scoring. This includes a 3-point scoring system divided into 0, not doing it all, 1, emerging skill, and full mastery. The administration time is aimed at 30 to 70 minutes depending on the child's age. The Bayley-4 has an extended floor to more easily test developmental delay and observe what a child can do. When the data was cleaned, items were reordered based on a combination of item content and item difficulty. The Bayley-4 retains all 5 developmental domains from the Bayley-3. These include social emotional behaviour, adaptive behaviour, cognitive, motor, and language. Bayley-4 retains 5 distinct domains to allow you to generate strengths and weaknesses across various areas of a child's development. The domains can be compared directly to each other. The Bayley-4 draws on the theory of typical normal stages of development. Play with objects begins early in infancy, with 6-month-olds capable of playing with a single object. Children interact with an object first by banging it. A few months later, the child can combine or relate two or more separate objects, beginning to show an interest in the similarities of objects. Around 9 months of age, relational acts begin to emerge. Relational acts include placing a spoon in a cup and putting a lid on a pot. By 2 years of age, the child begins to incorporate symbolic or pretend play. Children pretend to drink from a cup and put dolls to bed. Symbolic play becomes more complex with age, incorporating substitutions and fantasy in pretense. For example, a child aged 36 months may hold a hand to the side of his or her head and pretend to call someone on a make-believe telephone. The Bayley-4 has several caregiver items. These are designed to decrease anxiety in both the caregiver and the child. The information from the caregiver also describes the child's typical abilities across settings, reduces test duration time, and minimises missing scores due to the refusal by the child to complete a task. 5 caregiver questions were dropped before final 1 because the questions did not adequately assess the construct of the item, and the other 4 because of poor psychometric properties. The Bayley scales are used to identify children with developmental delay and provide information for intervention planning. Around 10% of children experience a delay in one or more areas of their development at some point in their childhood. The first assessment can be used to hypothesize and make an initial early intervention referral. The second assessment becomes more diagnostic, as it may indicate a pattern of delayed development over a period of time. You can educate the parent during the assessment. Ask the parent, how do they think their child behaved? Did they do anything that surprised them? Educate the parent about appropriate activities for their child. For example, they may be surprised that their 12-month-old can hold a crayon and scribble on paper. The Bayley scales are used widely in research, in clinical audits such as premature follow-up, and to determine the benefits of intervention, for example, a specialist program with an occupational therapist, and the effects on cognition, motor, and social skills. The Bayley scales are beneficial in a range of clinical settings and can be used by a range of trained professionals. Level B users, including allied health, such as psychologists, occupational therapists, speech pathologists, and physiotherapists, can use the Bayley-4. Ordering is restricted to Level B users. User Level M can also use the Bayley-4, and this includes professionals such as doctors in developmental practice who complete the workshop and then work under supervision. Other people, such as nurse coordinators, can work in a specific context, such as a research study. It is essential that people using the tool are familiar with child development and testing young children. They should also be familiar with principles of test administration, including establishing rapport. This can be a learning curve. Things to consider when establishing rapport are matching the tone of the child. For example, if the child is very expressive, you can be more talkative, but be careful not to hype the child up. If the child is quiet, you should use a soft tone of voice. Refrain from touching the child with any toys, and don't put things close to their face, for example, the squeaky duck. It is essential that the assessor maintains standard procedures and administers the items according to the administration manual. The assessor also requires an understanding of the psychometric properties, which will be required during the scoring components of this training. The assessor should be familiar with interpretation of developmental tests, reporting, and maintaining test security. The Bayley-4 has 5 distinct domains, including cognitive, made up of sensory motor, exploration, manipulation, object relatedness, concept formation, and memory, receptive communication, made up of pre-verbal behaviours, vocabulary development, including identifying objects, understanding plurals, pronouns, and tense, expressive communication, made up of babbling, word approximations, word combinations, turn-taking, vocabulary, including naming, and syntax, including the structure of sentences. The expressive language scale on the Bayley-4 also looks at quality of speech, such as articulation, or the clarity of expressed words. Fine motor, made up of prehension, visual perceptual integration, and motor planning. Gross motor, including the use and movement of limbs and torso, static and dynamic movement. The social-emotional domain is based on Stanley Greenspan's scale 2004 and includes emotional regulation, interest in the world, and engaging with others. The child's adaptive behaviour can also be assessed. You may like to use the adaptive behaviour to obtain additional information on how the child is functioning in a more typical environment. You may find it particularly useful if the child's behaviour prevents them from completing the Bayley-4 assessment, or if the parents indicate that the child's performance on the assessment items is not representative of their everyday skills. The adaptive behaviour domain is developed from the Vineland 3 by Sparrow and colleagues 2016. It includes the subdomains receptive, expressive, personal, interpersonal, play and leisure. It reviews a child's typical everyday functioning in the areas of communication, socialisation and daily living skills. Each of the different scales are made up of several items. Each child attempts a certain set of items based on their starting age and developmental ability. Children do not attempt every item in each scale. The social-emotional scale is a parent-completed questionnaire with a maximum of 35 items. Adaptive behaviour is also measured using the parent-completed questionnaire. Both questionnaires are contained in the one booklet. You may like to pause this presentation and look at the social-emotional and adaptive behaviour questionnaire. A Year 10 reading level is expected to complete the items. You may need to interview the parent with an interpreter if necessary. The Behaviour Observation Inventory is located on the inside back cover of the record booklet. This can be a guide for a mental checklist as you complete the assessment with a child, or you may like to complete this at the conclusion of the assessment. Please pause the presentation to look over the Behaviour Observation Checklist. You should always query the child's typical behaviour with the parent to ensure that you have observed a typical representation of the child's performance. Standard scores and scaled scores are good to view on this curve. Standard scores have a mean of 100 and a standard deviation of 15. Scaled scores have a mean of 10 and a standard deviation of 3. The scaled score of 6 to 13 spans the low average to high average range. See page 64 of the technical manual, and is highlighted by the aqua-coloured line. The red line depicts the start of the extremely low or developmental delay range. The blue arrows depict one standard deviation. You can see that the developmental delay range starts 2 standard deviations below the mean. You will need to have an understanding of these to fully appreciate the details on the standardisation slides. You can reflect back to this slide when needed. The Bayley-4 is an individually administered test. It must be administered in accordance with standards for educational and psychological testing. The test should meet the basic measurement assessment principles of validity, reliability, and fairness. The objective of the assessment is that it's non-judgmental and standardised. To comply with basic standards for psychological or developmental test use, the test must be an objective and standardised measure of a sample of behaviour, have a user manual with standardised administration, scoring, and population norms to assist with interpretation, have set items that have accepted levels of reliability and validity, and allow measurement of an attribute of the individual, for example, intelligence, personality traits, or development. In the next few slides, I will review the standardisation of the Bayley-4 so you can fully appreciate the validity and reliability of this very well standardised developmental tool. You can refer to the pages in the Bayley-4 technical manual as I work through the slides. It is important to understand how this test was made. Would we consider it to be a reliable and valid measure of development? The Bayley-4 is a very well standardised tool and is a leader in test choice for childhood research. The conceptual phase was used to determine an initial set of revision goals and included market research and expert panels. This was followed by the assessment lab process. During this phase, the Bayley-4 was administered via paper record form to 17 individuals and was designed to evaluate new items and propose modifications. It was used to determine the proper place to insert new items in the existing Bayley-4 item set, refine item instructions and scoring, and alter manipulatives and some item stimuli. A digital administration phase was designed to evaluate Q Global and assess the functionality and usability of the Bayley-4 on Q Global. During this phase, the interface was refined and new needed features were identified. Caregiver question focus group was also conducted to evaluate new caregiver questions, ensure items were understood by various educational levels, define specific words, and ensure language was familiar to caregivers. During the pilot study, the first blueprint or the first research version of the Bayley-4 was put to the test on 151 children. During the national tryout phase, the items were tried by a large sample of children, including those with special needs. This was followed by a US standardization phase to develop US norms and a separate standardization phase to develop Australian and New Zealand norms. In the next few slides, I will focus on the development of the culturally specific norms for Australia and New Zealand, which are based on the standardization phase of 716 children. The quality procedures used to collect the Bayley-4 Australian and New Zealand standardization data were designed to facilitate proper test administration and to assure that the test responses were accurately scored. Each examiner was familiar with Bayley-4 administration and qualified with a workshop and supplied with online materials for the Bayley-4. Every case was checked for accuracy by the Pearson research team. Examiners were informed of errors, retrained, and provided corrective feedback. The Australian and New Zealand norms were based on the standardisation phase of 716 children. The younger age groups are well represented where there is rapid developmental change. The sample gets thinner as they get older and may be less representative at an older age. 16 special groups infants, or 2.2% of the standardisation sample, were included in the development of the norms. The special groups included infants with developmental delay, Down syndrome, and those born premature. Stratification was based on the Australian Census of Population and Housing 2016 and the New Zealand Census of Population and Dwellings 2013. Parent education was categorised into 4 education levels. Education Level 1, Year 11 or below, was underrepresented in the normative sample, representing 9.1% of the normative sample compared to 11.3% in the Australian and New Zealand population. In regards to ethnicity, individuals in the Australian sample identifying as English and/or Australian, and individuals in the New Zealand sample identifying as New Zealand European were overrepresented in the standardised sample. Samoan, Chinese, and Indian ethnicity was underrepresented in the New Zealand sample. All Australian states were represented, as well as the North and South Island of New Zealand. New South Wales and South Australia were underrepresented, and Queensland was overrepresented in the normative sample. Looking more closely at the urbanicity, rural regions in Australia were underrepresented, making up 2.92% of the normative sample compared to 8.54% in the population. Urbanicity was well represented in the New Zealand population. Indigenous participants were incidentally recruited and well represented in both the Australian and New Zealand normative group. Aboriginal and Torres Strait Islanders made up 4.6% of the Bayley-4 Australian and New Zealand normative sample. This compares well with 5% representation of Aboriginal and Torres Strait Islanders noted in the Australian population. See page 20 of the technical manual. 26% of Maori children in the standardised sample corresponds well to the population. The social emotional scale is used to understand how a child uses all capabilities to meet needs, deal with feelings, think and communicate, and to establish goals for intervention and optimise positive parent-child interactions. The social emotional scale looks at the child's ability to engage in a range of emotions, to experience
express and comprehend emotional signals and elaborate emotional signals in words and play. The social-emotional stages of development change as the child matures. They become more reliant on language as the child ages. For example, to engage in two-way purposeful communication, it would be essential that the child be expressing themselves in words. The social-emotional scale is based on a sample size of 723 children and stratified to the Australian and New Zealand census according to parent education, ethnicity, and geographic region, with a ratio of 50-50 males to females. If two parents lived with the child, an average education level was used, with partial levels rounded up to the next highest level. The norms include 2.2% developmental risk factors, including prematurity, Down syndrome, and developmental delay. Adaptive behaviour is a child's practical, everyday skills required to function and meet environmental and cultural demands. There is variety amongst cultures. Australians tend to do more for their children than Americans when it comes to self-help skills. The Bayley-4 has culturally specific Australian and New Zealand norms for the adaptive behaviour based on 722 children. It is stratified according to the Australian and New Zealand census, according to parent education, race, ethnicity, and geographic region, with a ratio of 50-50 males to females. If two parents lived with a child, an average education level was used, with partial levels rounded up to the next highest level. The norms included developmental risk factors, including prematurity, Down syndrome, and developmental delay. In the next few slides, I will review the reliability of the Bayley-4. Please refer to the pages specified in the technical manual for more details. Reliability refers to the accuracy, consistency, and stability of test scores across situations. 152 children were tested twice with a retest interval of 1 to 43 days, with an average retest interval of 11.8 days. There was a high degree of stability over time, with a slight increase in stability across age groups. It is reassuring that there is greater stability at higher age ranges, as developmental change slows down as we age. For example, one would expect that a 4-week-old infant would show more developmental change in their motor skills in a 6-day period than a 9-month-old infant. Internal consistency measures whether different items on the same subscale measure the same thing. For example, are the items in the cognitive scale actually measuring the same thing? The correlations between different items are measured by R. Keep in mind a perfect correlation equals 1. Ideally, we want 0.8 or better. Based on the normative sample of 716 children, the average correlations range from 0.87 for the motor to 0.91 for cognitive, expressive communication, and gross motor. The average reliability coefficients for standard scores are 0.94 for language and 0.92 for motor, and are higher than those for scaled scores, as standard scores summarise the child's performance on a broader sample of abilities. The coefficients are comparable and in some cases better than those of the Bayley-3. Adaptive behaviour and social-emotional have similar reliability. Adaptive behaviour correlations range from 0.85 to 0.96. Social-emotional had reliability of 0.9. Both scales had good to excellent reliability. In regards to interrelator reliability on the adaptive behaviour reliability was generally good, but lower than internal consistency. This is likely due to respondents having differing familiarity with the child and completing ratings at slightly different times. Should two parents attend the assessment, ask the parent who spends the greatest amount of time with the child to complete the social, emotional and adaptive questionnaires. Reliability information for the special groups supports the generalizability of the instrument. As part of the US standardisation, the reliability for special groups was shown to be very good indeed, ranging from 0.97 to 0.99 in a sample of 412 children. Please refer to page 33 of the technical manual.
This is an equally reliable tool for children with clinical diagnoses or varying levels of development. In the next few slides, I'll review the validity of the Bayley-4. Please refer to the pages specified in the technical manual for more detail. Validity is the most important aspect of test development. Content validity determines if the test content is measuring what it is designed to measure. For example, is cognition measuring cognition? This is based on content literature and expert reviews. To look at convergent and discriminant validity, we need to consider the intercorrelations between the various subtests and between standard scores. In this case, the lower the correlation, the better. When we look at the intercorrelations on this slide, the scores show overlap. You may be thinking, shouldn't they be measuring something different? However, you need cognition to perform motor tasks. For example, you need to be motivated to walk to the other side of the room, or you need cognition to imitate. You also need cognition to understand and construct speech. Thus, there is always correlation between subtests. In this case, the correlations are very acceptable and indicate the subtests are indeed measuring different things. In regards to the social-emotional scale, the correlations are highest with language, as expression and gesture of feelings and understanding of language are important and essential in our ability to socialise and engage with others. To be expected, the adaptive behaviour language scale correlates most highly with the communication subdomains of the receptive and expressive. The correlations are in line with US correlations. Factor structure was determined by statistical analysis during the Bayley-3. A three-factor structure was determined from 6 months of age and consisted of language, motor, and cognition. The Bayley-4 has the same three-factor structure in order to look at child development and determine specific areas of strength and weakness. A two-factor structure was noted under 6 months, consisting of motor as one factor and language and cognition combined as the second factor. Let's take a look at the correlation with the previous edition of the Bayley scales, the Bayley-3. You may need to look at longitudinal research where the Bayley-3 is compared to the Bayley-4. They are sufficiently correlated to be compared. A perfect correlation equals 1. The mean standard scores for both measures are in the average range, and the effect size of the mean difference between the scores is small. The effect size for the subtest mean difference is also small, with the exception of the cognitive subtest. The corrected correlations between the two instruments are high, indicating that they measure similar constructs. According to the Flynn effect, Bayley-4 should yield scores that are lower than Bayley-3. This is the case. Now let's consider the relationship of the Bayley-4 to other scales that you may use or be familiar with. The Wechsler Preschool and Primary Scale of Intelligence 4th edition, or the WIPSI-4, is an intelligence test designed for children aged 2 years 6 months to 7 years 7 months, developed by David Wechsler. It provides subtest and composite scores that represent intellectual functioning in verbal and performance domains, as well as providing a composite score that represents a child's general intellectual functioning, called the full-scale IQ. Based on a sample of 104 children aged 30 to 42 months, as expected, the cognitive scale score on the Bayley produces the highest correlation with the full-scale IQ of the WIPSI-4, with a correlation of 0.79. The language scale standard score correlates highly with both the verbal comprehension index and the full-scale IQ. This pattern of correlation suggests that the 30 to 42 month age range, the cognitive and language scales assess a construct similar to general intelligence, measured by the WIPSI-4. However, children found the Bayley-4 much more engaging. As to be expected, the motor scale showed a lower correlation with cognition, 0.45. Cognition is moving away from motor at an older age. For occupational therapists and physiotherapists, let's look at the Peabody versus the Bayley-4. The Peabody Developmental Motor Scale 2, or PDMS2, contains 6 subtests that assess the motor skills of children from birth through to 5 years 11 months. The subtests are reflexes, stationary, locomotion, object manipulation, grasping, and visual motor integration. Composite scores include gross motor quotient, fine motor quotient, and total motor quotient. They appear to be measuring something similar, yielding high correlations for some motor skill areas. The highest subtest correlations are between the Bayley-4 gross motor subtest and the PDMS2 locomotion at 0.67 and reflexes at 0.63. A high correlation is also evident between the Bayley-4 motor scale standard score and the total motor quotient on the PDMS2 and fine and gross motor scales on each tool. For all of the speech pathologists, let's look at the preschool language scale, or the PLS-4, versus the Bayley. The preschool language scale aims to identify receptive and expressive language skills in the areas of attention, gesture, play, vocal development, social communication, vocabulary, concepts, language structure, integrative language, and emergent literacy. It is designed for ages birth to 7 years 11 months. No additional studies were determined to be necessary to establish the language scale subtests as valid measures of receptive and expressive communication, given the stability of content between the Bayley-3 and Bayley-4. When comparing the Bayley-3 to PLS-4, figures show a good correlation of 0.71, but are based on a fairly small sample size of 69. The content between the PLS-4 and the Preschool Language Scale 5 is consistent with how receptive and expressive language skills are assessed for infants and toddlers. See page 48 of the technical manual for more details. No additional studies were determined to be necessary to establish validity using the Bayley-4 and the Vineland-3 because the stability of the content between the Bayley-3 and the Bayley-4 was high. Moreover, the Vineland was used to develop the Bayley-4 Adaptive Behaviour Scale. This information is reported as part of the development of the Vineland-3. Please refer to Vineland-3 Manual, page 212, table 7.26. Based on a sample size of 50, the highest correlation is between the Bayley-3 Language Composite and Vineland-3 Communication Domain at 0.72. The Bayley-3 Motor Composite and the Motor Skills Domain is also highly correlated at 0.66. Let's take a look at how the Bayley-4 performs when used for various clinical groups. Autism spectrum disorder, or ASD, is characterized by impairment in social communication and interaction and the presence of restricted, repetitive behavior, interests, and activities. According to the Centers for Disease Control and Prevention, the incidence is 1 in 59 children, with the prevalence 4 to 5 times greater in boys. 31% of children with ASD have IQs below 70. Based on a sample of 62, 31 children with ASD and 31 matched controls, with an average age of 3 years, the mean subtest scaled score and standard scores for the ASD group were significantly lower than matched controls. More than one standard deviation was evident between ASD and matched controls in all areas. The receptive communication and expressive communication subtests produced the lowest mean scores. The ASD group performed almost 2 standard deviations below controls on the receptive language subtest and more than 2 standard deviations below controls in the expressive language subtest and language standard score. The language scaled standard score was in an extremely low range with a mean of 62.8, whereas the motor scaled standard score was relatively higher at 71.4. For children with developmental delay, it is uncertain whether their development reflects a delay or deficit. Therefore, the degree of delay varies. Classification in the developmental delay group means delay in 2 or more areas: cognitive, motor, language, social-emotional or adaptive functioning. Based on a sample of 114 children, 57 with developmental delay and 57 matched controls, with an average age of almost 2 years, prematurity was accepted as a comorbid condition. Prenatal drug alcohol exposure, Down syndrome and ASD were excluded. The mean subtest scaled scores and standard scores for the developmental delay group were lower than matched controls. Less than 1 standard deviation was evident between developmental delay and matched controls in each area except the expressive language subtest. The language scaled standard score was in the very low to low average range, whereas the motor scale standard score was in the low average range. Receiver operating characteristics, or ROC curve indications, good accuracy in distinguishing children in the developmental delay group from matched controls. ROC scores are classified as follows: 0.9 being excellent, 0.8 to 0.89 being good, and 0.7 to 0.79 being fair, with the ROC indication curves of 0.82 in this case. 32 children with developmental delay were compared to matched controls on the adaptive behaviour scale, with a total sample size of 64. Subtest scale scores were significantly lower for the developmental delay group than matched controls. In receptive and expressive language, developmental delay was more than 1 standard deviation below controls, as well as interpersonal relationships. Less than 1 standard deviation was evident between developmental delay and matched controls in personal and play. Standard scores for communication were in the very low to low range, whereas the other standard scores were in the low average range, with all areas more than 1 standard deviation below matched controls except daily living skills. Down syndrome is the most common generic cause of moderate intellectual disability. The severity of intellectual disability of children with Down syndrome is on a continuum ranging from profound to borderline cognitive functioning. Developmental delay and hypertonia are early manifestations. In addition to intellectual disability, relative weakness in expressive language, syntactic processing, and verbal working memory are frequently found. Visual and spatial memory is typically not as impaired. In a sample of 108 children, 54 Down syndrome and 54 matched controls, subtest scale scores were significantly lower for the Down syndrome group than matched controls. In cognitive, receptive communication, and gross motor, children with Down syndrome performed more than 2 standard deviations below controls, and less than 2 standard deviations was evident between Down syndrome and matched controls in expressive communication and fine motor. The standard scores for language and motor were in the extremely low to very low range. Language development is highly variable and progresses as children interact non-verbally in both receptive and expressive formats. 17% of young children present with language delays of unknown etiology, not associated with cognitive, genetic, or sensory problems. As many as 60% will catch up with peers by 4 years spontaneously or with intervention. Early indication and intervention are vital to improved outcomes. Conceptualizing language delays as transient and as the child grows, viewing persistent language difficulties on a continuum of severity of impairment is useful when assessing, for instance, 18 to 35 months for language delay and 36 to 42 months for specific language impairment. Language delay typically follows correct sequence, but at a slower rate. For a sample of 50, including 25 children with language delay and 25 matched controls with a mean age of 26.4 months, subtest scaled scores were significantly lower for the language delay group than matched controls. More than 1 standard deviation was evident between the language delay and matched controls in both receptive communication and expressive communication. Standard scores for language and motor were significantly below matched controls. Language was in the very low to low average range. Receiver operating characteristic curve indicates that the cognitive and language scales provide good accuracy of 0.89, in distinguishing the children in the language delay group from matched controls. The classification accuracy of the language scale alone is also good, 0.86. For a sample of 50, including 25 children with specific language impairment and 25 matched controls with a mean age of 39 months, subtest scale scores were significantly lower for the specific language impairment group than matched controls. More than one standard deviation was evident between specific language impairment and matched controls in receptive communication and expressive communication. Standard scores for language and motor were significantly below matched controls. Language and motor were both in the low average range. The ROC curve indicates that the language scales provide good accuracy of 0.8 in distinguishing the children in the specific language group from matched controls. Children born premature are divided into several groups depending on their degree of prematurity. Under 28 weeks gestation are classified as extremely premature and make up 1 to 2% of all births. 28 to 31 weeks are classified as very premature. 32 to 33 weeks are classified as moderately premature. 34 to 36 weeks are classified as late premature. 75% of premature births are in the late premature group. In general, the smaller or younger the infant, the lower the mean group IQ. According to Marlowe, 2005, for each week of gestational age below 32 weeks, the average decline in IQ scores is 1.5 to 2.5 points. However, keep in mind that this group that Marlowe presented in 2005 may be a different group to what we are seeing now. This same gradient of problems is found with later academic achievement, visual motor skills, language, and neuropsychological functions. Moderately preterm do poorer with respect to cognitive and attentional skills than do older preterms. Infants born late premature also have poorer outcomes than do their full-term peers. In a sample of 70 moderate to late preterm infants and 70 matched controls with an average age of 19.6 months, the preterm infants performed within the average range on all subtests with means of 8.1 to 9. All subtest scaled scores and standard scores were significantly lower than matched controls, less than 1 standard deviation below matched controls. Language and motor scales were also in the average range, but nonetheless significantly different than matched controls, with moderate effect sizes. Keep in mind that this represents a more typical group of moderate to late preterm infants and excludes conditions that are often associated with poorer outcome. In a sample of 66 very and extremely preterm infants compared to 66 matched controls with an average age of 20.6 months, the very preterm and extremely preterm group scored lower than the matched control group on all subtests, with large effect sizes, and scored lower than moderately preterm and late preterm counterparts. The average language scaled score was in the low average range, and the motor scale standard score was in the very low range. The gross motor, fine motor, and cognitive scaled scores were the lowest. Keep in mind that this represents the group of very and extremely preterm infants that do not have conditions typically associated with poorer outcome. The incidence of cerebral palsy in the general population is 1 in 500 births. This figure increases in children exposed to asphyxia, extreme prematurity, or other non-optimal prenatal and perinatal events. 60% of those with cerebral palsy fall into the mild range. As much as 50% of those with cerebral palsy have intellectual deficits. Developmental coordination disorders are found in 5 to 10% of the pediatric population, defined as poor motor coordination without clear evidence of neurologic pathology. In a sample of 80, with 40 children with cerebral palsy or developmental coordination disorder and 40 matched controls with an average age of 26.6 months, the following was noted. All mean subtest scaled scores and standard scores for the motor impairment group were more than 1 standard deviation lower than the matched control group. Subtest scaled scores and standard scores were all greater than 1 standard deviation below average, and language and motor scale standard scores were in the very low range, with the motor scale standard score lower than the language score. The cognitive scale score was the second lowest, with the gross motor score the lowest. These broad discrepancies most likely are also affected by the children in the sample with secondary classifications. When looking at classification accuracy, the receiver operating characteristic, or ROC curve, indicates that the motor scale provides excellent accuracy of 0.9 in distinguishing the children in the motor impairment group from matched control. Tan and colleagues reported 10.2% of pregnant women have consumed alcohol within the last 30 days, and 3.1% have engaged in binge drinking during the same time period. Babies are commonly exposed to polydrugs in addition to tobacco and poor prenatal care. In a sample of 88, 44 with a history of prenatal drug or alcohol exposure, and 44 matched controls with an average age of 24.4 months, the mean subtest scaled scores and standard scores for the prenatal drug and alcohol exposure group were all significantly lower than the matched control group. The cognitive scale score was the lowest at 5.2, and large effect sizes were evident for all scores. All of the clinical group studies support the use of the Bayley-4 with children who have clinical diagnoses, and the Bayley-4 is an appropriate assessment to identify children functioning outside the expected range. You have now completed this online learning. I hope that you have a better understanding of the components of the Bayley-4 and how rigorous the standardization process was to make such a comprehensive developmental assessment tool. I also hope that you have a better understanding of clinical needs groups and the use of the Bayley-4 in these populations.